Hello, everyone. Thank you for joining Advize Health for our webinar on risk adjustment coding. I'm your host today, Brittany Hurd, and I'm pleased to welcome you to today's event. Before we get started, I want to give you a little background about Advize Health. At Advize Health, we analyze processes, create protocols, and implement solutions for healthcare entities of all sizes. Advize Health has been in existence for more than 12 years and employs more than 60 of the industry's top experts nationwide. Advize does not subcontract employees, so you can rest assured that your needs are addressed by someone that is specifically assigned to your organization. We offer many services, including healthcare compliance analysis, medical documentation auditing services, and educational opportunities for numerous topics such as ICD-10 training and clinical documentation improvement. Our priority and promise to the healthcare community is to always tailor our services to our clients' individual needs and provide cost-efficient services that every entity is able to afford. Our speaker for today's webinar is one of Advize Health's medical auditors, Robert Chacon. Robert is a certified professional coder with AAPC, ICD-10 certified, and he's an auditor with background in HEDIS and HCC. Today, he will be focusing on risk adjustment coding, the different types, the various tools to use, and much more general information about it. Robert will start off by going over the agenda, and at the end of the presentation, we'll also have time for Q&A. Housekeeping items related to the Q&A. If you have any questions throughout the webinar, be sure to submit them via the questions or chat box in the GoToWebinar interface and send them to all organizers, and I'll make sure Robert has time to answer them at the end of his presentation. Also, please be sure to expect an email with the certificate with the 1.5 CEUs, a copy of the presentation, and a recording of the webinar within 3 to 5 business days of the completion of this presentation. I'll now turn it over to Robert, who's going to begin the presentation on risk adjustment coding.
Hello, everyone. Can everybody hear me? Awesome. Okay, again, welcome, everyone. My name is Robert Chacon. I am a auditor here at Advize Health, and today we're going to go through a brief overview of HCC coding and what we know in the model of risk adjustment. So again, as Brittany mentioned, I'd like to save just a little bit of room towards the end for a few questions, but I will say there's no real agenda for today's presentation. It's going to be specific. The information that I speak to is going to be specific to HCC coding. It's going to be very, a synopsis view of the information. So again, I'd be happy to answer any questions you may have. If we don't get to your question towards the end of the presentation, I'll have an email address present. If you guys feel free to email me at that email address, I'll be happy to answer your questions. So again, welcome everyone, and we will get started. Again, just a quick bio. Robert Chacon. I've been certified for more than 7 years. And again, been highly involved in many different components of the coding world. Practice management, coding, auditing, educating, consulting for about the last 12 and a half years. I have served many terms as president, vice presidents, and local chapters along the way. So again, have a lot of experience in sitting in and hearing out the different local chapters. And just a little background about myself. I reside in Las Vegas, Nevada. I'm originally from Texas, and where I've done a lot of my work in the prior years, it's been in the state of Texas, and I was able to venture out on the West Coast where, we have that Nevada and California combination of being able to reach out to individuals pretty much, on both sides of the state. So very fortunate to have that. Again, procedural diagnostic coding experience, CPT ICD 9 and 10, HCC coding risk adjustment models for our RADV and RAC audits. Quality assurance, so just QA on pretty much the majority of all just basic and extensive CPT and diagnostic codings. I do know HEDIS. I've been doing HEDIS for about 8 years. I am a HEDIS trainer here at Advize, and we're hoping to ramp up that HEDIS component in our company, so that's very exciting. Develop and deliver audit plans for physician and compliances. Again, it just goes hand in hand with coding and auditing for many different projects that we have here. And of course, executive leader with management roles throughout my career. In every company that I've ever worked for, it just seems that it's in the role that I present. It just seems to always work good and coming together with management and educating specifically for the projects. Again, as mentioned, I'm an auditor here at Advize Health. I'm based out of Las Vegas, Nevada. Here's my email address. We'll have this more information, or this email address, towards the end of the slide, and I believe everyone will be able to jot that down if you don't have a second to do it now. Okay, so again, I don't have an agenda, but I just wanted to kind of do an intro to HCC. And it's, again, the information that is going to be spoke to today is specifically in regards to risk adjustment coding, which specified to HCC. And so there is information that is actually not really elaborated on, but I will tell you that there's so much in HCC coding that we could talk all day long. So again, I just kind of giving you a brief overview of the generalness of HCC coding, and hopefully you can get the idea if it's new for you, or even it's refresher for some of you that have already participating in this type of coding. So what is HCC? What does it stand for? Hierarchy Conditional Category, that's pretty much what it stands for. And again, category of medical conditions that map to a corresponding group of an ICD-9 or 10 diagnosis codes. So that actually is about 3,000 diagnosis codes that map to what we know as an HCC or an RX HCC code. And again, if you've worked HCC coding, you know that a chronic diagnosis of diabetes is going to map to either an RX HCC or an HCC code, which would be the numeric number from 1 to 87. Why is this important for our physicians? Well, we ask ourselves that and specifically for the individuals that are on the call that are coders and RNs, for you guys that are working particularly in the office with your providers. We ask, if you're not doing anything in regards to HCC, why is it important? Why should we be doing it? That's a good question. And so in my logical thinking, in an era of rising medical costs and reduced payments from CMS, Medicare, Center for Medicare and Medicaid Services, concentrating on HCC coding and documentation is one of the best ways to eliminate the gaps in care and ensure that money's not being left on the table. And this is what everyone wants. With the right focus and tools, it can be done by you. So again, in a brief synopsis of this phrase here, it is you, the individual, that is responsible in the office. Maybe it's a bill, or maybe it's a code, or maybe it's an RN, office managers, that you individuals that are actually can have that perform and deliverance to your provider to say, hey, maybe we're missing out on leaving money out on the table, per se. And so this is a way, a form of coding that can be captured and done and alleviate the possibles of money left on the table. What is Medicare risk adjustment? Well, Medicare risk adjustment is the method on how Medicare pays managed care plans. And just elaborating to that, Medicare introduced paying based on diagnosis in the year 2000 or so, in hopes of providing managed care plans with more accurate and timely payments. There are specific diagnostic codes for illnesses at its severity, in which managed care plans use to report data at least once per calendar year. And this is in order to account for the appropriate risk adjustment. And again, this program is known as RAPS, which is a risk adjustment processing system. So again, for the ones that are involved with HCC, that there's, letters that you may receive from CMS saying, hey, we're doing this calendar year, we're doing what we know as, and they may even say an audit, but it is gathering information and validating the information that you provide in regards to diagnosis for illnesses for your patients. And so really important to kind of understand, why are we doing this? Why is it a benefit in conjunction to other thoughts? General principles of HCC. So again, the risk adjustment diagnosis must be based on clinical medical record documentation from a face-to-face encounter. And let me just back up a second. The information that I'm going to speak to here, again, there's tons of other general principles, but these are some of the ones that actually are at the top of the list per se. So, again, it's just a brief overview. There's probably a handful more that could be added, but these are the most common ones. And of course, a face-to-face encounter is most important to be able to validate the data off the medical record into, when you're doing HCC coding. Coded according to the ICD 9 or 10 guidelines for coding and reporting, assigned based on dates of services within the date collection period. Again, that's just pretty much saying stick to your coding guidelines, stick to the basics, and then if it's a request that you do receive from any type, from Medicare requesting the data, or even an commercial insurance company, they may ask for a specific date time frame that actually they're collecting the data. So again, it's the best way to respond to that would be sending the information they requested within the time frame, so that it's better validation for the collection period that they're looking for. Acceptable provider types. So again, there's a handful of provider types that do not fall in the HCC risk adjustment model, and we'll get into it further in the slides, but there's a list of just a handful. The medical record documentation must support an assigned RX HCC or an HCC code. Again, as mentioned earlier, you have 1 to 87 probable HCC codes that are attached to a specific, or I should say assigned to a specific diagnosis. So that's just what that's referring to. And what we all know and go by is document, document, document. No documentation equals no justification for any services billed. And that's kind of a common ground for any type of auditing or medical record validation. We have to make sure that our providers are aware, and I know, we tell them once, we tell them, several times, but just, give them a little more insight and a different approach in a different way. Hey doc, document is key. And so again, for this model of coding, if there's no documentation, we cannot justify this or validate it for any of this particular coding. HCCs are similar to diagnosis related groups, which DRGs use for inpatient hospital payment, in the way that they use diagnosis code in a formula to to set patient risk scores, which are then used to set reimbursement rates. And let me go over that just again real briefly. HCCs are similar to DRGs, used in an inpatient setting, in which diagnoses are formulated to set patient risk scores, which are then used for reimbursement rates. So roughly, the sicker the patient, the higher the score, the higher the reimbursement. Okay, and that's kind of where that last sentence kind of explains it in a nutshell, maybe more in generic terms. It is, we love our patients, we're there for our patients, we take care of our patients. The sicker they are, the higher the risk adjustment code, and then of course, based on specifically risk adjustment coding and auditing, it's higher the reimbursement rate. So keep that in mind for individuals, in any practice, any specialty. Internal medicine, it has a lot of chronic diseases, even family practice. So whatever specialty you may be in, this is very important to know in regards to HCC. Okay, discharge summaries and H&P. And again, I'll refer that all the information that is spoken to on the slides is specific to HCC coding. Okay, code hospital discharge summaries and H&Ps using outpatient guidelines. Do not code uncertain diagnosis from a hospital discharge summary. Remember when coding from the discharge summary to use the discharge date as your data service and then use the date of the note for the H&P. This is kind of just a general information. It's nothing in particular with HCC, because when you do, and the fact that you would submit your information from a discharge summary, you probably will use the date of the discharge for your information that you submit over. If you do have H&Ps, again, if they were admitted on the same day, discharged on the same day, it could technically be the same note, the same data service, I should say. And so that information will be the same data service either way. So just keep that in mind. The following facilities are unacceptable for risk adjustment. And we can definitely not validate any type of HCC coding for these specific facilities. And that is a freestanding ASC center and a freestanding renal dialysis facility. There are specifics, and towards the end of this presentation, there are some really valuable websites that have more information on the reason why we can't accept it from these facilities. So definitely take a look on those websites to give you more of an insight. Documentation. So again, documentation with only the diagnosis codes listed. If the documentation only provides a diagnosis code, so for example, 244.9, 401.9, and the assessment of plan, use your coding tools to help you validate each diagnosis code into the proper description, making sure that the diagnosis code description is coded to the highest level. That's a very general coding habit. We just want to be refreshed to think that if we see a diagnosis in the assessment and plan, we know that we should probably use a proper description to validate it. Coding the medication list. So we should not code from a medication list if the diagnosis code does not have support, linkage. An example of that would be that Synthroid is the medication, is on the medication list, but no diagnosis of hypothyroidism is found on the data service. Should we not, and so that in that case we would not code the hypothyroidism. Now there's several different ways to code from a medication list when we're doing HCC. This is just one particular example. So again, in this particular example, if there's not a linkage between the medication and the diagnosis on the actual report, then we would not code it. Now, there are some instances where you will have hypothyroidism and the PMH, which is a prior medical history. And we'll get into that here in a little bit, where there could possibly be the fact that you could use that out of the PMH to validate the Synthroid medication. Okay? Visit summary. Notes stating the summary of today's visit. If the documentation visit summary is clearly just a visit summarization and is missing key components of the visit, so if it's missing physical exam, review of systems, we would not code from these types of notes. So again, just keep in mind that it has to be a full face-to-face encounter, a full SOAP note, however you envision a compliant note. Then that would be, the physical exam or the chief complaint, the HPI, the physical exam, the ROS. As long as all that is present, that seems to be a logical, complete note. In the case that a summary visit is just summary of today's visit, that we cannot use for this type of model of coding. Working diagnosis. So we do not code diagnosis documented as probable. suspected, questionable, rule out, or working diagnosis, or the similar terms including uncertainty. And I think that's kind of the highlight here, is just to remember if there's anything that's labeled as, uncertain, we cannot use it. And that's, again, another general coding guideline for many other, for many different types of coding. But specifically for HCC, we want to leave those alone, and that's not to be validated. Rather code the conditions to the highest degree. So again, here's an example. A PMH says diabetes. Medication is metformin, and the assessment says diabetes working diagnosis. So the code for this in regards to HCC would be your E11.9. And then working diagnosis codes cannot be coded, but the diabetes in the PMH is supported by the current medication. And earlier, just a slide ago, I mentioned that. So again, when we get into PMH, I'll mention it again, and maybe it'll, kind of make sense there in the PMH. But in other words, if we have a medication that is on the medication list, and we have diabetes in the PMH, and it's supported, you can use it. Okay. This last phrase is kind of a two-parted phrase. So working diagnosis cannot be coded. But if diabetes is in the PMH and it's supported, then with the medication, then we can use it. So this is, again, there's a lot of different variables. So just keep it all in mind, and the questions will always arise with that information, and it's just making sure you have clarity on that. Screenings. Screening is the testing for diseases or diseases precursors in seemingly well individuals so that early detection and treatment can be provided for those who test positive for the disease. So again, this is your well visits that consist of all your screenings, your routine mammos, etc. And so routine mammos for women over 40, a fecal blood test for everyone over 50, and anything to rule out a fetal anomaly for pregnant women over the age of 35, because the incidence of breast cancer and colon cancer could be probable because of their age in the general population, as in the incidence of Down syndrome in older mothers. So again, this information here is kind of crammed, but all in all, it's just making sure we know the screening, the age, and the particular specialty that you're dealing with, so that you know the differences. The testing of a person to rule out or confirm a suspected diagnosis because the patient has had some signs or symptom is a diagnostic exam, not a screening. Again, the testing of a person to rule out or confirm a suspected diagnosis because the patient has had some sign or symptom is not a diagnostic exam, it's a screening. In these cases, the sign or symptom is used to explain the reason for the test. A screening code may be a first listed code if the reason for the visit is specifically the screening exam. It may also be used as an additional code if the screening is done during an office visit for another health problem. A screening code is not necessary if the screening is inherent to a routine exam, such as a pap smear done during a routine pelvic exam. Now, I know there's a lot there to comprehend, but again, just read over it. If you have questions for clarity, let me know, and we'll get you your right answer. Should a condition be discovered during the screening, then the code for the condition should be used and not the screening code. So in a nutshell, for screenings, we depending on the specialty, you may have, for instance, if you're a family practice provider, you may have a patient come in and they're doing a well women visit and they do have a PAP done on the same day. This is all just to make sure that you understand the differences in a screening and a visit. And when I say a visit, I mean signs and symptoms of a diagnostic exam, not specifically a screening. So there's a difference in the two. 6 steps of clinical coding. So, this is just kind of a little map that's kind of written out to give you specifics on once I begin validating the HCC information, how do I know what step to go to and where and how far do I go? And so with that being said, before you begin, review each page of the chart to ensure that the entire chart is for the correct member. That is important, of course. If the chart contains information from another patient, well then of course we're not going to pursue on any further. Do not code. Step 1. Is the data service within the approved time frame of the audit? Yes. If it is, verify that the correct patient name is listed on the document before proceeding. If it's not, then we want to skip and go to the next encounter. If it is, then we go to step 2. Step 2, do I have an acceptable document source? Yes. Is it a legible document? Can I read it, whether it's handwritten or whether it's printed out, from an EMR and it's a copy? Can I read this? Can I read the whole thing? Is it legible? If it is, then we go on to step 3. If it's not, of course, go on to the next encounter. Step 3, do I have an acceptable provider type? And this is important because there's only acceptable provider types for HCC. So again, do I have the acceptable provider type? And I have credentials here because we have to make sure that the provider's an MD or a DO. Also, valid provider credentials could be an NP or a PA. So again, if it is and it's documented, whether it's handwritten, if it's handwritten, then you're able to have the letterhead at the top of the page, which does count for being able to constitute a valid hand signature. If it's an electronic signature, we want to make sure that we have MD or DO, PA, MP after the provider's name. So again, we want to make sure the credentials are present, as that's important for a valid signature. So if the acceptable provider type is there, we're going to move on to step 4. If it's not there, then we move on to the next encounter. So step 4, is this encounter complete with the valid SOAP note? Data service and patient name specifically. So do we have a data service? And do we have the valid patient name on there? And so is it a valid SOAP note? Do we have a complete SOAP note? Do we have a complete medical record that we can validate from every aspect of the record? If it is, then we move on to step 5. If not, we'll go ahead and skip and go to the next encounter. Step 5 is going to be acceptable physician signature. And that kind of piggybacks from step 3, where I mentioned an acceptable physician signature type for an electronic signature is going to be your provider name, the credential, the date, and the time. Okay, so those components must be present with an electronic signature. And we'll get into more of that in the slides to come. And if it's a handwritten signature, do we have a letterhead with that provider's name listed on top? So again, those are acceptable physician signatures. If it's there, we move on. If not, we skip and go to the next encounter. And of course, step 6, we code the chart. We validate the information. And so code all supported diagnosis codes documented while coding to the highest level. So again, that's just basic. We want to make sure that we're coding the chronic diagnosis for HCC to make sure that the information requested is, to the highest level. Coding at a data service level. We code all supportable medical conditions within the approved data collection period. We do this from acceptable document sources and acceptable provider sources using official coding guidelines and CMS guidelines for risk adjustments. And before I begin here, I want to just mention that all of us know, coders, RNs, whoever's in the office, billers, office managers, you guys always follow the official coding guidelines when you do anything specific to coding. But for HCC, we advise that you do that, of course, and also know that CMS has guidelines to use for risk adjustment. And this information that I'm providing today is strictly that. The guidelines on a risk adjustment model from CMS is exactly what I'm presenting today. So that's kind of what that's referring to. So just so you know the difference in the two, and we all know that, we all do official coding guidelines, but know that CMS has their own guidelines for risk adjustment model, which would be considered HCC. Okay, we also code status, history codes from the pertinent visit. Again, you always have history of codes, and we'll get into that further along. Prior medical history, any type of history, family history. Some of that we can take information from. It's not really to say that you can take a diagnosis code from, but you can use that as to help you validating a diagnosis code. Support is defined as proof of the disease or the condition was addressed. Is it being treated? Was monitored or evaluated? Or was substantiated by additional information? So again, that's kind of referring to the next phrase down where it says, look for meat. What's the medical condition? So in the HCC world, we like to use an acronym, and there's a newer acronym, but for the most general senses of HCC, meat is the most common way to kind of dig through your report to find the information that you need, okay, for this specific validation. So this is what MEAT stands for. MEAT stands for monitored, evaluated, assessed, or addressed, and T for treated. So every time when we look at a medical record and we're looking in an HCC mode, we want to think in the back of our head, I want to make sure that I can validate MEAT, this MEAT acronym, with each medical record, or the data service you're looking at, I should say. So is this, data service, is the diagnosis being monitored? Is the diagnosis being evaluated? Is the diagnosis being assessed or addressed? And is it being treated? And so if you have MEAT on that one particular data service for that diagnosis, that's golden. That's what you want to strive for. That is going to get you your higher risk score, your higher reimbursement in the HCC world. So again, it's very important to know that MEAT acronym is used all the time during HCC coding to make sure that data service and that diagnosis is confirmed with the MEAT acronym. And we'll talk about it again further on, through the slides as well. Supportable medical conditions. To code a medical condition, it must be supported in the medical record. Support can be provided by, again, a list of medications that can be linked to a particular disease or condition, a review of medications or a new prescription that is noted to be specific for a disorder, or which has the narrow usage limited to a certain disorder. And again, that you don't see that very often, but I will tell you with ICD-10 that a lot of the prescriptions that are being electronically produced in the provider's offices now have diagnosis codes on the prescriptions. So again, it hasn't been confirmed that we could use this as a valid form. It is recommended that you could use that as a guide. So again, at the end of the slide, there's some great websites. Refer back to those websites for specific and updated information. This information is probably about a month in, so it's very up to date. But again, just to know for ICD-10, your prescriptions, a lot of the electronic softwares, the medical records, have diagnosis codes written on the RXs. So that could be something we could use. For example, 5 milligrams of prednisone daily for 5 days for your asthma. In this case, prednisone would be acceptable as support because although prednisone has many uses, it has been directly linked by the provider for the asthma. So again, this is just giving you an idea of linkage. There's many different ways of linkage depending on what you're looking for. But this would be a way where the physician has actually linked the medication to the specific disease and has written an RX for this. So this could be used. Now, in my world, I would think that this is presented in an actual SOAP note. So actual, inside the medical record, the SOAP note for that date, not specifically written on an RX form. And I think we're not talking RX here, we're just talking in general. So something you will see on a SOAP note. Notes reflecting, excuse me, notes reflecting results of laboratory or radiology reports. So example, a chest x-ray confirms pneumonia. You can use this if it's clearly supportive, okay? And there's many different ways that this can be presented. So it's very, very, you got to be cautious in the way that you take this information because, we can't just have an x-ray report and at the bottom somewhere it says confirms pneumonia. That's not what this is saying. It's just saying notes reflecting the results. And personally, I like to see this in a SOAP note. So in a SOAP note, if we have, as a follow-up from the primary visit, saying, the patient as follow-up for, the chest x-ray. And then somewhere in the note it states chest x-ray confirms pneumonia. And so that right there it's a supported document that you can use. Not really an x-ray report that says confirms pneumonia or even has a diagnosis code of pneumonia anywhere written on it. That is not a valid supportable document to use in the HCC world. Virtually any other documentation that affirms the diagnosis was addressed in any manner during the encounter. And again, I bring up the MEET acronym, again, monitored, evaluated, assessed or addressed and treated. Because if you, memorize this, it's easy to memorize. And even if you put this into play on your day-to-day operations, if you said, you know what, we're going to start using the MEET acronym, you talk to your providers, you talk to your office and say, hey, let's start using the MEET acronym and making sure when we close out at the end of the day that we do our best to make sure that all of our visits for that day have been monitored, evaluated, assessed, or treated. That's going to get you golden with being able to make sure that you are in that risk adjustment model. And that will, make you fall into the higher reimbursements brackets for, certain chronic diagnosis. So again, this is easy to remember, it's easy to follow, and a SOAP note is easy to say, hey, here are all the components, but maybe if you say MEET, is MEET here, is MEET on every SOAP note, that will allow you to prepare yourself and the providers and the staff members and being just a little proactive with HCC. Okay, support of prior medical history. So again, this information that I'm going to mention is specific to HCC. There are two types of history V codes, personal and family. So again, personal history codes explain a patient's past medical condition that no longer exists and is not receiving any treatment, but that has the potential for reoccurrence and therefore may be required continual monitoring. So that's pretty self-explanatory. A lot of that could be, your cancers or whatever the case may be. If you have something that is, no longer existing, but could be potential for recurrence, and therefore may require continual monitoring. If it does happen, that's just, personal history. If a condition is listed as a history, or in the prior medical history portion of your SOAP note, you must have an active treatment for that condition in order to code it as a current condition. Otherwise, the V code history would be used. For example, in the prior medical history of the SOAP note, you have hyperlipidemia. In the assessment and plan, you have check lipid panel, return in 3 months. In this case, there's no evidence of an active treatment, medication. The lab would be considered monitoring for recurrence, so 272 or M78.5 would not be coded. Okay, so again, this is just specifically talking about history, the history, personal history, and family history versus your past medical history. Okay, so again, just specific for histories in regards to, can I code this if it's here? If I have hyperlipidemia and the assessment and plan does not consider it an active treatment, then you would not. And again, this is just a general synopsis of this. There's going to be questions in regards to this for elaboration, and there's answers for those questions. So again, if you have any questions, jot them down, and we'll should do our best to answer all your questions. What do we audit from? We do not code from a standalone problem list. However, a problem list that is part of a face-to-face visit and shows evaluation and/or treatment for each condition that relates to the ICD-9 or 10 code on a particular data service is acceptable. So again, if we have a problem list that is standalone versus if we have a problem list that is part of the face-to-face visit, then we can use it. Okay? So again, and again, specifically for HCC, it's a specific rule that we have for this particular problem list, and so a lot of times it may be that you have a problem list in your medical record that reflects the same thing in the face-to-face visit. So in that case, if it's the same thing, you can use it, but know that it has to be part of the face-to-face visit. Cannot be a standalone problem visit. And a lot of times with the years of doing HCC, I see a problem list that has tons of chronic conditions that we could capture. And if it's not mentioned in the face-to-face visit, we can use it. So keep that in mind. List of the acceptable document types. So anesthesia notes, cardiac cath report, consultation report or letter, a discharge summary, an ER record, an H&P, a post-op report, and of course a progress note, office note. And again, we'll go further into a cardiac cath report. That gets kind of tricky for HCC. You'll notice I say you can use it, but then when we move further along, we'll say specific ancillary reports cannot be used. Cardiac catheter is considered somewhat of an ancillary procedure or department, and so if we just have a cataract catheter report, we cannot use it. But if we have the cardiac cath report inside for that data service and it's mentioned of in that face-to-face, we can use it. So again, this is just a general. Specifics are further on, and then of course questions we'll get into. List of unacceptable document type, demographic face sheets. Of course, we cannot use face sheets. Pathology reports, path reports, we cannot use. A problem list, as mentioned above, standalone, we cannot. A signature log, we cannot. So again, those are just a list of some acceptable and unacceptable. And they each have their own specific, but this is just a general overview. Unacceptable document types. So any document with dates of services outside the data collection period. So again, this is going to be only specific to if you receive a request in regards to HCC or any type of risk adjustment model validation from whether it be CMS or an insurance carrier. It would be good that you submit your information on the data service that it's actually asking for. Okay, try to stay within the data collection period because that's what it's focused on. The data collection period is the time frame that the information is being validated for. A list of a patient condition, problem list, medication record as a standalone document. So a list of patient conditions that cannot be used. Whether that's something that you use in your office and you've constructed, you and your provider, or even if it's something that the patient brings in. that's been taking monitoring at home. That is a list of patient conditions, and it cannot be used. EKG, echo, Holter monitor, and pathology reports as standalone documents. And this is where I mentioned just a slide before. They can get kind of tricky with, we say we can use certain ones and then we say we cannot. So again, know that each type of ancillary report, depending if it's mentioned in the actual SOAP note for that data service, can be used. But if it's a standalone document, just like a regular Holter monitor and echo, that cannot be used as probable validation. A diagnostic report that has been interpreted. So again, a lab report, and that's going to be just your basic lab report that has been, you have the results, and it's, has the high or the low. Any type of diagnostic reporting that has, some interpretation to it cannot be used. Is it clear that the encounter was not a face-to-face? So again, if you don't think that it's not a clear face-to-face visit, then we can't use it. For HCC specifically, it has to be a face-to-face visit with a valid provider. Physician sign attestation alone. So again, if it's just a physician, summary, a page with a physician signature that has your diagnosis codes and a CPT code for that day, we cannot use that. Physician, DRG coding summaries. Again, this is kind of neat. There's elaboration on this, but just to know that DRG and coding summaries in an inpatient setting, some of them cannot be used. Some can, some cannot. So again, there's specifics, and there's websites that have more information on the specifics. Radiology reports and nursing notes. And that's an RN, an RN sees the patient. Patient comes in for, a flu vaccine. The patient has a history of, hypertension, diabetes, what have you, and those are chronic conditions. We cannot use the nurse note. It has to be signed off by an MD, or I should say a sufficient provider type for this model coding. Unacceptable provider types. So again, the following list of providers that are not acceptable. LPN, LVN, an MA, a CNA, a registered nurse, a radiologist, and a nutritionist. So again, and just piggyback to what I just mentioned on an RN note. So any notes that are signed off with this particular credential and provider, we cannot accept for HCC coding. Again, this is kind of just a snapshot of acceptable provider types. If you notice, there's quite a bit on here, and it's pretty much, your basic specialties. So, your family practice, your internal medicine, cardiology, neurology, etc. So here's a list of the acceptable provider types. Common chronic mappable codes, and I use the word mappable in this presentation because these codes are mapped to a HCC code. And remember, if you went back to the HCC codes 1 through 87, it is mentioned that the 1 through 87 is attached to a specific diagnosis code that is actually a chronic condition. So that's the mapping. The mapping is a diagnosis code that maps to an RX HCC or an HCC category code, the 1 through 87. So again, here's some common ones. If you look at this list and your provider, does these day in and day out, diagnoses your patients with these particular chronic conditions, maybe you start getting in the HCC mode, and so that these diagnosis codes are so common that maybe there's chances for higher reimbursement, and specifically for HCC. So again, and these are common ones There's tons more, but these are the um, general mappable chronic conditions. Proper definition of a physician signature. I think I mentioned it earlier. Provider name or initial, acceptable provider credential, the date signed, and if it's an EMR, the proper electronic signature is going to be making sure that you have the provider name, credential, and date and time. Appropriate signatures may be in any of the following formats. So again, it can be in a handwritten format, it can be in an initial format, and electronic signature format. So the most common is going to be your electronic signature. And if you're not on an EMR system, which is, there's some out there that are not, handwritten signatures will be common, and then initials. And initials, I don't really don't see much of initials, but if you do see the initial, it follows the same guidelines as a handwritten signature. And the handwritten signature is that the signature is present and that they have a letterhead up top somewhere on the page for that data service, having the full provider name, credential, and location. So again, I don't see much initials, but the main two different ones here are the most common ones, handwritten and electronic. Electronic signature. I think I covered this already, but the CMS rules for HCC auditing require below provider first and last name or initial, provider's last name, provider's credential, the date authorized, signed, or validated. So again, the acceptable electronic signature can be taken from anywhere off the note. It doesn't have to be at the end. It can be at the beginning. Some of the electronic medical record softwares, put it in different places. So as long as it's somewhere on that note for that data service, it's valid. Okay, so the next few slides, and we'll try to, we only have about 30 more minutes or so. So we will, the next few slides are going to be the actual diseases, classifications within the particular ICD-9 book. They're not all here, but the majority of them are, so we'll get through this. Again, these are just coding tips. They're highlights of the particular categories, okay? Symptoms, signs, and ill-defined conditions, coding tips. And again, these tips are specific for HCC. Only code signs and symptoms when related to a definite diagnosis that has not been established. Do not code signs and symptoms that are integral to a disease process unless otherwise instructed by the classification. For example, BPH with your lower urinary symptoms. So your ICD-9 or ICD-10 N40.1, the tabular instructs the coder to use additional code to identify the symptoms and then list the associated symptoms. So again, we all know for BPH with LUTS, we want to make sure that we know which one we code first with as far as being the identifier for the code. And that's basic coding guidelines. It's nothing, different than what you're already doing. Only code signs and symptoms that are not routinely related to a disease process. So for example, you have chest pain with the diagnosis code of acute MI. You do not code the chest pain, code the acute MI. Jaundice with the diagnosis of hepatitis. Do not code the jaundice, code the hepatitis. So again, this is specific to, it's general guidelines specific to the HCC coding. V and Z codes, they're common codes. Again, it's a snapshot of common codes that you'll see that are commonly used. The most common that I see are towards the bottom. You have your long-term use of insulin for our diabetes patients, and then the BMI, which, BMI is more and more commonly being noted on medical records, or, so if it's 40 and over, if the BMI is 40 and over, that is a huge chronic condition for HCC. And so that, that tells a lot. It goes in many different directions as far as, is the patient diabetic? Is the patient, hypertensive? If the patient have cholesterol issues? All those are all factored in. So just keep that in mind as far as BMIs being noted, whether they're 40 or over or not even 40 or below. It's always real good to document the BMI. E-codes, external causes of morbidity codes, are used to identify the cause of an injury, such as a fall or suicide attempt, adverse effects on poisoning, including the intent and the place of occurrence where the accident or injury took place. So again, you're going to have these particular codes that are going to go in conjunction with, the laceration of an arm or what have you. If they fell off a skateboard or what have you, this information is going to fall into place. Attempted suicide codes are the only external causes of morbidity codes that map to an HCC. So specifically for HCC, know that the causes of morbidity is actually very important in this world. And so it's not always the case, but just keep that in mind. They appear in the tabular section titled Suicide and Self-Inflicted Injuries. Suicide attempt must be clearly documented by the physician in order for you to use these codes. It's recommended that the diagnosis documented as probable, suspected, questionable, rule out, or working, or similar terms indicating uncertainty. So again, it's just making sure that it's documented clearly that the patient has mentioned suicidal attempt or any type of suicidal self-inflicted possibilities. Example, suicide attempt with laceration of the right wrist by a knife blade. Again, this is general. You want to index to the wound, and then you want to index to the actual morbidity of the suicide attempt by the knife. Infectious and parasitic diseases. These are just, wanted to give you some key acronyms. This is just general, HIV. We see a lot of this common, with just whatever practice. So these are just common acronyms to just keep your, keep your mind open to. Infectious and parasitic diseases. Sepsemia describes a bacterial infection that is spread into the bloodstream so that the infective agent is disseminated throughout the body. So again, keep in mind that sepsemia is really, really, in my world and what I've dealt with it before, it can be complicated, but it is rather easily once you get the progression of it down. And so below, from start to finish, here's a flow of the illness due to the infection. So again, it starts with just a with a very general bacteria infection. Then, if depending on the severity, it's gone up to severe sepsis with shock, and then multiple organ dysfunctions, and then possibly death. So again, this is just information on the flow of sepsemia and kind of where is the patient, in whatever particular stage of the flow. Infectious and parasitic diseases, coding tips. And a lot of this is focusing on sepsemia, and sepsis. Septic shock indicates the presence of a severe sepsis. If the causal organism is not noted, you want to code the A41.9, which is unspecified. Because, with ICD-10, we have a lot of unspecified codes. But if we can be very, very specified, that's where we want to be. Negative or inconclusive blood cultures do not preclude a diagnosis of sepsemia or sepsis in a patient with clinical evidence of the condition. So often antibiotics administered prior to the condition or hospitalization cause negative test results. So again, that's just saying, regular lab results that are being performed for that particular disease may or may not have an effect on your finding. If a non-infective SIRS progressive to a septic version, report only the septic version. Never report the two codes, R65.1 and then the X, so the digit, the further digit, the specified digit. Documented hypotension with severe sepsis is coded as septic shock. Urosepsis N39.0 is a non-specified term. If documentation states strip sepsis, code A41.9 and the R6510. So, if you code sepsis and there are many different ways, and knowing the flow and the condition of the patient, these are basic guidelines and just kind of giving you, an idea of how to find that definite condition of the illness. Infectious and parasitic diseases, again, coding tips for HIV and AIDS. HIV causes AIDS, but is not synopsis with the AIDS. Code the Z21 HIV status for HIV positive patients without symptoms or any type of infection. It may be documented as HIV positive or known as HIV. Code B20 HIV disease, AIDS, for patient documented with AIDS, HIV diseases, or having at least one infection. Code the B20.0 only for confirmed cases of AIDS. The provider's statements alone that the patient is HIV positive, has AIDS, or AIDS-related illness is sufficient enough to assign a code. Other evidence or support is not required. Code in all addition, all manifestations for the infection. More than one diagnosis code may be required in order to fully report the patient's condition. If documented, use the additional code to identify the HIV infection, in addition to T-cell disinsufficiency. So again, these are general coding tips. If they're what you already do, great, that's fine. Just know that they are also the same guidelines for the HCC model. Endocrine, nutritional, metabolic diseases, and immunity disorders. These are some key acronyms that you'll see, very, very common. Diabetes 1 and 2, insulin-dependent diabetes, and so forth. Coding tips for diabetes. Some type 2 diabetics use insulin. When documented, code also Z79.4 for long-term use of insulin. May be documented in a variety of ways. So again, if you have a document of long-term use or any type of documentation that they do use insulin, you can use this information. So again, long-term use insulin, the acronym for diabetes, that's insulin dependent, on or uses insulin, documentation again of the actual drug that's listed in the medication list linked to the assessment and plan. If the type of diabetes is not documented, the default code is the E11.9. Poorly controlled diabetes is not the same as uncontrolled diabetes, unless the medical record clearly states non-controlled or out of control or uncontrolled. Code assessment should be for the non-stated or the uncontrolled. Now, there's a lot there in that last statement. So, in a nutshell, it's just pretty much stating, make sure we know if it's poorly controlled, it's not the same as uncontrolled. Okay, and that's based on your knowledge and what you know in the coding guidelines. Some more coding tip for diabetes complications. A causal link must be established to code a complication of the diabetes. So the following verbiage is acceptable. Diabetic, due to, caused by, derived from, related to, result of, secondary to, or consequence of. So you can see many different link phrases to, making note on the medical records that, the patient is actually, a diabetic patient that is linked to a medication or linked to any other chronic condition. And so, again, these are just common verbiages. You can see, there may be different verbiages as long as it's something that is, not unacceptable. Again, diabetes manifestation is where it kind of takes us to. The following conditions can still be reported as a diabetic manifestation using the language diabetes with, coma, gangrene, and so forth. So again, linking the diabetes manifestation to a specific or other chronic disease. Okay, coding tips, high cholesterol. Up and down arrows are not acceptable. So for example, if you have the up arrow cholesterol and the assessment and plan for HCC, it's unacceptable to take that and validate it. Again, document it if it has high cholesterol. We want to use the E780, hyperlipidemia, E78.5. High cholesterol with high triglycerides, then E78.2. Here's some more key acronyms for disease organs. A lot of these are going to be, labs, that kind of thing, but at least it's some common key acronyms. Coding tips is specific for blood and blood-forming organs. Sickle cell. Do not mistake sickle cell trait for sickle cell anemia. Sickle cell trait reported the D57.3 indicates that the patient is a genetic carrier of the sickle cell disease. If its documented includes sickle cell trait and the disease, report only the disease. So again, that's just a common ground for making sure, it being specified to the highest level of the condition for the patient. When the documentation lists anemia, neutropenia, and the thrombocytopenia, only assign codes for that particular diagnosis, which D61.818, which includes all three. So if it's documented clearly, make sure that we're using the right code for D61.818. When assigning a code from the category D60 through D64, also assign a code from the chronic condition causing the anemia. That's just the basic coding guideline. You want to code the D63-1, anemia in CKD, in addition to a code from the 585 category for the CKD. So again, if it's a patient with anemia and CKD, we want to make sure that we capture the stage of the CKD and the anemia. Mental disorders, here's some key acronyms for that. Mental retardation, any type of, just the basics. There's tons more, but here's just an idea. Mental disorders, coding tips, specifically anxiety and depression. When coding anxiety and depression, this is the following. Diagnosis code F32.9, depressive disorder, and F41.9, anxiety state, unspecified, for a diagnostic statement of depression and anxiety. So we all know they're separate if they're documented separate. If they're together, then we code them together. Okay? Where there's no association between the two conditions, we assign them separately. If, however, the provider documents them both, we code them together. So that's kind of what I just mentioned. If they're separately, we do them separately. If they're noted together, then we go to the F34.1. All right, mental disorders. Again, a few more examples. Anxiety/depression. We want to code the F41.9 and the F32.9 if it's depending, again, on how it's documented. And for this particular example, a slash in a medical record does not confirm the relationship between the two conditions. So the slash may have several means such as and or, okay? So I know that, when I first mentioned the first example, you're thinking, well, I just thought you said, that we could combine them. Well, if it has a slash, it doesn't really combine the two. So just remember that the slash, doesn't really combine the two. It's not confirmation that it's one. Anxiety with depression. So if anxiety with depression, we would code F34.1. If it's anxiety and depression, then we want to code it out separately, F41.9 and F32.9. Some key acronyms for nervous systems and sense organs, your Alzheimer's, your Parkinson's disease, etc. Coding tips for your nervous system and sense of organs. A single seizure does not constitute epilepsy. If the documentation discusses seizure or seizures, but no pattern of a disorder is mentioned, the correct code to capture is the R569, other convulsions, which does map. If documentation has a seizure disorder without further explanation, we want to index the direct readers to G40.909. A simple rule to follow is to remember that a single episode reported as a symptom, so the R56.9, but seizures linked to the word disorder are reported differently as a G40.909, epilepsy unspecified. So I think, in a nutshell, it's saying symptom versus disorder. Do you know the difference? Is the difference documented? And if it is, then there's a separate code for that. So know the differences and exactly know what is being documented specifically for seizures. Coding tips for pain. The only pain code that maps to an HCC code is a typical face pain. It has to mention those specific words to be validated, and that would be G50.1. Chronic pain syndrome is not to be confused with chronic pain, and therefore should only be used when the provider has specifically documented. So again, piggyback to what I just said, it's make sure that it is documented specifically. A typical face pain, chronic pain, there's a difference. We know syndrome, so just keep that in mind. Diseases of the circulatory system, some coding tips. Again, hypertension specifically. Follow these rules when coding hypertensive, high blood pressure, or elevated blood pressure. And these are specific to HCC. Hypertension unspecified, I-10. High blood pressure, the I-10, unless it is an incidental reading, RO 3.0, and that's new, for the ICD-10 world. Malignant hypertension, I-10, must be stated as malignant. Same thing with your benign hypertension, make sure it's stated. Elevated blood pressure without a diagnosis of hypertension. So again, it's going to revert back to your reading of RO 3.0. Do not code a hypertension based on a symbol. We mentioned that earlier with cholesterol. It follows the same rule with the blood pressure. And we do not code a hypertension on the value of a blood pressure reading. And so this is specific to HCC, okay? I want everybody to understand the materials again, and I'll say it again, is specific to the HCC coding world. Diseases of the circulatory system, again, hypertension. If you have a diagnosis of hypertension, you must use the following meat as support. Treatment of the medication or the prescription, verbiage of stable, control, uncontrolled, assessed, reviewed, worsened, or improved, blood pressure reading. You cannot use a blood pressure reading to support a history of hypertension. In order to bring it, any diagnosis out of the history, active treatment must be documented. And again, that's actually one full phrase there. Sorry for the next bullet. It says you cannot use a blood pressure reading to support a history of hypertension. In order to bring any diagnosis code out of the history, it must have an active treatment. Okay? High blood pressure can be coded as hypertension if it is clear that it is not a one-time incidental reading. So again, example, if the document states high blood pressure and is on the medication, this would indicate a condition that is actively being treated and is clearly not an isolated event and would be coded as hypertension. Elevated blood pressure is not equivalent with high blood pressure or hypertension. Elevated blood pressure is reported separately as RO 3.0. Some more hypertension information. When you have documentation of hypertension and CKD, including chronic renal failures, N19, and renal sclerosis, N26.9, a causal relationship is assumed. These disorders do not have to be directly linked in the diagnostic treatment statement in order to be coded as a combination. In this situation, you could assign a hypertension code from category 403 in addition to a code to identify the stage of CKD. For hypertension and a heart disease, a causal relationship cannot be assumed. Hypertensive and a heart disease must be linked by the provider with such terms. Post-op hypertension as a complication of a surgery. However, if a patient has documented hypertension prior to the surgery, you could not use this code, but rather category it to the I-51.4, the I-51.9. Okay, circulatory coding tips for MI. MIs that show a CT segment change to an ECG are called ST elevation, MIs, or STMI. So again, usually the STMIs involve full thickness of the heart muscle. The non-STMIs do not involve a full thickness of the heart muscle. Only subcategories I-21-4 report what is called a non-transmural or full thickness of an MI regardless of the site. This is just some basic information on MI. Old MI 412. If it's more than 8 weeks old, we want to consider it healed and or history of MI. We would consider that the same thing. Anytime you see documentation of an old MI, you would code an old MI regardless of the presence of the MI. The history itself is support. Note, if MI is found on an EKG, it is coded as 412 as long as it's not an active MI. So again, going back to using an EKG and an MI, if it's linked together, if the EKG is referred in the report that the patient has MI, the patient had an EKG, it's noted, then you can use it because there's linkage. If we're just basing it off an EKG report, we cannot use that. Diseases of circulatory, coding tips. Again, codes from the I-2510 to I-25-9. So in other words, your 4110 category codes may be reported to link the cause underlying disease. Chest pain not linked to CAD or angina is coded RO7.9. Intermediate coronary artery syndrome, ICS, is also referred to as unstable. Or an acute coronary syndrome is reported with the I-20.0. Unstable angina often precedes, and MI is common in patients with CAD. So a lot there as well, but just know the differences in what the patient has, the condition the patient is in and what is documented. Congestive heart failure, I-59. Look for notation in the chart of a previous bypass and the type of graft that was performed. For example, if a patient has a CAD with a cabbage, it would be assigned the I-25-9, assigned unspecified type of vessel, native, or graft. That's basic. CAD or native artery is coded I-25-10. And then, of course, your history of cabbage, the Z95.1. Key acronyms for respiratory. Here's some common ones. Respiratory coding tips. When coding all allergies, if the medical record does not specify the allergy, it's an allergic reaction, nor the cause, you will code the J3089. Pneumonia is a common lung infection with symptoms that may include a cough, fever, shortness of breath, green tea, phlegm, or chills. With a confirmed diagnosis code of pneumonia, none of the symptoms listed above could be coded because the integral of the disease itself. So make sure, again, symptoms that actually rule out the infection. The challenge for clinical readers will be to carefully audit each encounter to establish any causal relationship in between the two. So again, it's what I just mentioned. Make sure if there are symptoms that are that could have caused it, or is it really a bacterial pneumonia? There's a difference, and there's different distinctions. Pneumonia related to a ventilator, a VAP, is assigned to the J95-851. In the event the organism is documented, additional codes could be reported. So an example, the VAP due to MRSA would be coded as the J95-851 and the A49.02. Some more coding tips in regards to COPD. It is a generalized term. It's used to describe, as we all know, your chronic obstructive pulmonary disease and also your chronic obstructive bronchitis, asthma, and so forth. Conditions that comprise of COPD or obstructive chronic bronchitis and emphysema, there's the codes. All asthma codes are categorized to the J45. If the medical record does not link asthma to allergic rhinitis, do not link it. Code it separately. Okay? So again, if it's not linked together, if it's not documented, you want to do them separately. Unspecified COPD is this code, J449. Acute bronchitis, J20.9, is due to an infection organism. If acute bronchitis is identified along with COPD, assign the code J440. If you do not assign, then J20.9, in this case, because it is, or you do not assign, let me slow down here. You do not assign J20.9 in this case, because it is included in the combination code. So again, there's the breakout of the different bronchitises and emphysemas and all that stuff. Again, it's the basic knowledge of how to code what's documented. If a medical record states acute bronchitis with COPD, you want to make sure that you assign the J44O because of what is specifically mentioned, acute bronchitis overrides. So again, just keep that in mind. COPD with the acute, without mention of acute bronchitis, is also coded as J44.1. When a patient is admitted with both the COPD and pneumonia, we code both. Digestive system, coding tips. Gastric ulcers are coded thus far. Here's just kind of a brief rundown. I want to just kind of skim. Documentation uses erosion rather than ulcer. Perforation stomach conversely leads to a peptic ulcer. And also, if there is any type of surgical procedure that would be considered to support the Crohn's disease, it is such as Z93. Some more coding tips. If both of a stage of CKD and ESRD are documented, assign the ESRD only. Renal insufficiency and renal failure are two distinctly different renal conditions, although these terms are sometimes used interchangeably. So again, just make sure we know the difference in the two. Report dialysis status codes to capture the patient's need for dialysis. This code is not reported with codes from the category B56. Since dialysis is inherent to all these codes, patients may undergo kidney transplants for ESRD. The transplant, in some cases, mitigates but does not eliminate the underlying kidney disease. So keep that in mind as well if you have patients that have the kidney transplant. The kidney transplant status and CKDs are documented. You want to record both. For the patients with chronic kidney diseases and hypertension, report a code from the category I-12.9 or I-11 in addition to the code for the CKD, unless the hypertension is described as secondary, or the CKD is specified as due to a cause other than hypertension. All right, classification of a pressure ulcer requires two codes. A code for the subcategory to report the site and the pressure code, and one from the L89 point whatever X to report the stage of the ulcer. Let me rephrase that. So again, you want the site and the stage. There's two codes, a code of the site and a code of the stage. A documented heel pressure ulcer should not be coded. A documented healing pressure ulcer should be assigned if the stage is not further documented. Multiple sites may be documented with the multiple pressure ulcer codes. However, no code should be reported more than once. Again, some more coding tips. Chronic ulcers follow different rules for reporting than pressure ulcers. Keep that in mind. The sites of chronic ulcers of the lower extremity are reported with the codes L97 subcategory. These ulcers are typically manifestations of an underlying disease. So for example, you have your venous hypertension and you have other arteriosclerosis of extremities that lead to the restriction of blood flow to tissue within the lower extremity. So that's a mouthful of information there, but again, it's knowing the difference and what's documented. When reporting chronic ulcers of the lower extremities, always consider that the cause of the ulcer may, and the code additionally, the site of the ulcer. So again, chronic ulcers of lower extremities, always consider the cause of the ulcer and then code additionally the site. If no code is cited, it is acceptable to report the ulcer solely with the code by itself. Carefully consider whether the malignancy is active or historic. Let me back up. Neoplasms, and this is some coding tips for neoplasms. Carefully consider whether the malignancy is active or history of. Determining the nature of the neoplasm. If you have a history of a neoplasm with the current treatment, code the active. If the documentation states no recurrence or resolve, code the history. Some medications are prophylactic, so keep that in mind. Read the documentation to determine if the cancer is a history and if the medication is being used to prevent recurrence or still present and being used by a treatment. So again, kind of gives you just making sure the difference in the recurrence or active or history of. Primary and secondary. Primary cancer refers to the original site of the cancer. Secondary cancer pertains to the additional site where the cancer has spread. And we all know, METS is considered a term to define the cancer has spread. So if it's a MET2, then we know it's a secondary site. MET from, then we can refer it to as a primary site. And that's just some key terms to know the difference in if the cancer has spread and if it's to or from. When coding a secondary carcinoma, also code the primary neoplasm. When the primary site is not identified or known, we want to do the C80.1. When there are two or more secondary sites, code each site as secondary in addition to the primary site. It's common for cancers to spread to more to one site. To spread to more than one site. All right, diseases, musculoskeletal, connective tissues. Okay, osteoarthritis is reported with codes from categories such. Encoding depends upon whether the arthritis is localized or generalized, and whether it is primary or secondary. Again, that's basic coding guidelines. Rheumatoid arthritis, which is a very common chronic condition for HCC, which would be your MO 6.9. Then you have acute fracture versus aftercare. Again, it's going to be connective tissue, or to the same musculoskeletal if they have a fracture, versus aftercare. The guidelines define an active fracture as newly diagnosis when the patient is receiving active treatment for the fracture. The subcategory M84.4 would be appropriate for an acute pathological fracture for initial surgical or emergency treatment. Aftercare is described as an encounter after the patient has completed active treatment for the fracture and is receiving routine care for the fracture during the healing or recovering phase. Examples would be such: cast changing or removal, medication adjustments, removal internal fixation device, and follow-up visits. Aftercare codes are designated by V54.X. It is imperative that the proper code be distinguished between the acute care and aftercare. Injury and poisoning, coding tips. Only burns classified to the extent of the body surface involve third degree mapped to an HCC. So anything third degree or higher is going to be the only HCC mappable code for burns. Okay, so specifically for burns, a third degree burn involves full thickness of the epidermis or dermis with all layers involved. The burn may be described as deep necrosis, would be referred as the same thing. Often two codes will be required. One code to identify the site and another code to identify the severity of the burn. only a second code to identify the total body surface affected by the burn. So again, this is general information on coding burns, but know that HCC for a third-degree burn is mappable. Also report an associated infection, so if they have some infection that has caused or, due to the burn, that also need to be reported. Non-healing burns are coded as acute burns. Necrosis or of burned skin should also be coded as a non-healed. A key element to remember in reporting complications of care is the established causal relationship between the condition and the care that it has caused. Alrighty, so we are done with the specific classifications. I want to just go ahead and kind of wrap up. I know that it is a lot of information very quickly that was presented. Again, it was just a brief overview of some of the highlighted information. And so with that being said, reach out for questions. We'd be more than glad to have our team, answer your questions. That's what we're here for. So again, feel free to do that. The presentation, I believe, is going to, you'll have access to have a copy of that. So again, you can refer to this information. It is, valuable information. So again, with that being said, we'll kind of wrap up here the last few slides. Risk adjustment, what's at stake? So as healthcare moves on from fee for service to focusing on risk adjustment, you must pay close attention to providers' documentation. In a risk-adjusted payment model, the more severe of the complex of a diagnosis, the higher the risk value is. A risk adjustment value is assigned to each diagnosis code that falls into the payment model. Codes are then grouped into what we know as HCC codes. So that is kind of just renamed what we kind of went over in the process of how HCC, risk adjustment payment models, affect us, okay? Physician services and hospital claims are the main source of the data that is driven by this type of model. Many providers in both settings, outpatient and in, neglect their diagnosis code documentation and reporting. If medical documentation lacks the accuracy or highest level needed to assign the most appropriate diagnosis code, then all our providers face the possibility of reduced payment in a performance-based model. Okay, so again, if it's something that you haven't been doing, and it's something that hey, let's start doing this. Let's start thinking in an HCC model, a risk adjustment model. Then that's pretty much where maybe you want to be, because it's going to allow you to be in a higher risk value, which means the possibility of that extra income for the procedures, or for the diagnosis that are being validated for the patients. Here's the sources. Following websites have great resource. Your CMS risk adjustment page is very, very sourceful. AMA has a lot of good information. The AMA has one of the best HCC blogs, so they have a lot of blog information, let alone here at Advize, we have an amazing blog site that we have information that is continuously being thrown out there. So feel free to hit up on AMA and view their information, but certainly come out on our blog page and we'll have information for you. That's direct to the information presented today. So let us know and visit these websites for more information. AHIMA and Academy, of course, they have certifications in the particular risk adjustment mode. So again, should something you want to really pursue in, take a look. All right, so here's my contact information. There's my email address. Jot it down. If you want to shoot over an email, feel free to do so. I know it was, again, a lot of information in a short period of time, but I'll be happy to answer any questions and and via email going forward. So with that being said, I believe we're almost done here. If you want to turn it over to Brittany.
Yes, thank you so much, Robert, for all that great information. So now I'm gonna try to go over just a few questions. I know we're running a little bit over, so I'm just gonna ask you one or two questions and maybe just make it very brief. And like Robert said, you're more than welcome to reach out to him and discuss anything further. So the first question, Robert, is regarding provider signatures. What if the credential is demonstrated in the heading of the note and then signed off electronically without credential, i.e., patient was not seen today by Susie Provider MD and then electronically signed by Susie Provider?
Yes, so that is common. We will see that ultimately the electronic signature is going to trump the letterhead if we have an electronic signature. So we would primarily go with the electronic signature if you have that on the medical record. So if you have an electronic signature, we want to make sure that's complete. If it's not complete, then we can revert back to the letterhead. But again, if the letterhead is only effective if it's a hand signature, a handwritten signature for the provider.
Okay, great. So just the last question I'm going to ask is, what about the problem list within an EMR note? Is that considered standalone versus a problem list on the back cover of a paper chart?
Yes, so standalone, again, the standalone, if it's a standalone piece of paper, with the problem list that is attached or a separate piece of document within the medical record, it cannot be used. If the problem list, in most EMRs have somewhat of a problem list, a template, so their SOAP note has a template, and problem list is on there, then that's valid. So again, if it's a separate document, a separate piece of paper, it's considered standalone. You cannot use that. And a lot of the EMR systems if you don't have it already for the information, you can always customize your template to be able to, make your template visible for a problem list. So again, if it's not on there already, maybe you get with your vendor of your software and have them see if they can add a problem list field in there so that that information comes over versus having a separate document.
Perfect. Thank you so much for that, Robert. So we do have other questions, but unfortunately we're not going to have time for them. But we will send an email out to all the attendees with the questions and the responses, the answers from Robert, so you all get all that good information. And just to wrap everything up, thank you all for attending today's Advize Health webinar on risk adjustment coding. You should expect to receive an email with the certificate with the 1.5 CEUs, a copy of the presentation, and a recording of this webinar within 3 to 5 business days. Please be on the lookout for our next webinar on prepayment and post-payment reviews that will be held on February 11th. And thank you everyone for attending, and I hope you all have a great day.